Excuse me. Thank you very much, Mr. Chairman, for this kind introduction. First of all, I would like to tell you how I'm very happy to be in Egypt since this COVID pandemic. We lose this meeting for 3 or 4 years, and I would like to thank and to congratulate the president of this conference, my friend, Professor Gamal Serrour, for inviting me and for his friendship. Thank you so much, Gamal. So we are going to speak about a difficult topic concerning the adenomyosis. I'd like first to thank all the people in the department to collaborate with me for the management and the research, scientific and clinical research for the patients. So first we will go to discuss together about the diagnosis and after to see about the management. There are three main clinical symptoms concerning the adenomyosis: the pelvic pain, the heavy menstrual bleeding, and the infertility and the miscarriage. And you have numerous data who demonstrate that because of the adenomyosis, you have menorrhagia, you have impact on the fertility, natural fertilization or in vitro fertilization, and what is very important in the management, an impact on the pelvic pain. Recently, a meta-analysis demonstrated clearly with the IVF or ICSI that the impact on adenomyosis will decrease significantly the live birth rate and will increase the risk of miscarriage. And recently, it was published 2 months ago in the department, we look at the impact on the live birth rate of the association of adenomyosis to endometriosis. And we clearly demonstrated that when you have an associated adenomyosis, you significantly decrease the live birth rate in ART, and what model you use to perform the meta-analysis, you can see the impact of the age, the impact of the ovarian reserve, and the presence of adenomyosis. And on the opposite, when you look at the association to an endometriosis to the adenomyosis concerning the spontaneously early miscarriage rate, we demonstrate that the association of these two diseases will significantly increase the risk of miscarriage, and this is specifically observed when you have a diffuse adenomyosis rather than you have a focal adenomyosis. And when you look at the multivariable analysis, this observation is specifically important for the patient with deep infiltrating endometriosis. But very interesting, you have now new papers who look at the impact of the adenomyosis on the quality of life. And in the team of Carmona in Barcelona, they demonstrate that concerning the quality of life, you have no difference between the adenomyotic patients and the deep endometriotic patient. But if you compare the adenomyosis patient with no adenomyosis or no deep endometriosis patient, you have a significantly negative impact of the adenomyosis on the sexual life of the patients. They look also in the same department with different questionnaires on the quality of life and mental health for the patient, and you can see also the negative impact of the adenomyosis. And finally, they look at the impact concerning the work impairments and the cost of the management, and it is significantly negatively affected when you have adenomyosis. So all these elements are very important to take into account for the management of these patients. So what are the clinical symptoms of the endometriosis? You have the abnormal uterine bleeding, the gynecological pain symptoms, the infertility or recurrent miscarriage, local pressure, and gastrointestinal or urinary tract symptoms. But what are the problems of these clinical symptoms? First, you have a great heterogeneity concerning the symptoms. None of these symptoms are specific of the adenomyosis. So with the questionnaire, the clinical examination, you can have only a suspicious of adenomyosis, and you must not forget that in 30% of the cases, the disease is asymptomatic. It is the reason why we need to work with the radiology in order to improve the diagnosis of the endometriosis. And first, you will use the transvaginal ultrasonography, and you have numerous parameters which demonstrate that it's perfectly possible to perform the diagnosis of the adenomyosis. It was published in the consensus, the MUSA consensus in Europe, and it will be possible to have the diagnosis of the endometriosis. The other option is the MRI, and on this slide you can see that you have not only an adenomyosis, but also a focal posterior adenomyosis related to an endometriosis bowel nodule near the torus uterinum of the patients. And the recent meta-analysis demonstrate clearly that the specificity and the sensitivity of these two options, transvaginal ultrasonography or MRIs, give comparable results concerning the possibility of the diagnosis of adenomyosis. And when you look for the transvaginal ultrasonography, it seems that the best criteria to perform the diagnosis is the echogenic subendometrial lines and buds. So all these elements are very important. Why? Because previously the prevalence of the endometriosis was completely unsuspected. And now we know, because of the use of the MRI or the possibility of the transvaginal ultrasonography, that this disease is very frequent even in the young patients. And you can see that in the left part of the slide, it was a publication from Professor Petraglia in Florence, in Italy, and it demonstrates clearly that for patients very young, 24 years old, he obtained with the transvaginal ultrasonography a diagnosis of adenomyosis in 30% of the patients. That wants to say that 1 out of 3 patients you see in your consultation, they have an adenomyosis even if they are very young. And in parallel, without any connection, we do exactly the same study in Paris with the MRI. And what we observed, exactly the same percentage for patients by mean 30 years old, we have 30% of adenomyosis at the MRI. Possibility for the future to improve the diagnosis with the transvaginal ultrasonography is to perform the measurement of the stiffness of the myometrium, and you can see that you have a significantly increase for the patient with adenomyosis. And what is very interesting, it is a recent paper from Guo in China. It demonstrates clearly that the myometrial stiffness value is correlated to the importance of the heavy menstrual bleeding, and it's correlated also to the severity of the dysmenorrhea, the fact that you have an adenomyosis, and the uterine size. So the frequency, the prevalence is very important. But as for the endometriosis, you have 3 phenotypes with the superficial lesions, the oma, and the deep nodules. We have also a great heterogeneity for the adenomyotic patients. So you have numerous classification of the adenomyosis. You can have the diffuse adenomyosis. You can have the focal, the local, the adenomyoma, an intramural cyst, and you can have also what we call the focal adenomyosis, either in the anterior part of the uterine wall or in the posterior part of the uterine wall. And if we look at our experience in Paris concerning the association between the deep endometriosis and the focal adenomyosis, you can see that in our experience, in 50% of the cases, when you have a deep endometriosis, you have an associated focal adenomyosis, and this rate is 70% in cases of intestinal endometriosis. So what are the relationships between endometriosis and adenomyosis? We look at the patient with diffuse adenomyosis, and we demonstrate that the percentage, the prevalence of the diffuse adenomyosis is exactly the same. 30% of the cases, whatever you have endometriosis or not. And the second point is that there is no correlation between the endometriosis phenotype and the occurrence of the diffuse form of the adenomyosis. For the focal adenomyosis is a completely different story. The focal adenomyosis is not observed in the patient without endometriosis. It is in relation with endometriosis, and the association is correlated with the endometriosis phenotype and significantly observed for the patient with deep infiltrating endometriosis. So perhaps because of this clinical observation, we have two different pathogenesis for this disease. First, for the diffuse adenomyosis, a progression from the endometrium into the myometrium, and perhaps because of the association between the focal adenomyosis and the deep endometriosis, after the regurgitation, if there is the possibility to infiltrate the intestinal wall, why it is not possible for these endometriotic cells to penetrate in the posterior wall of the uterus. And this is confirmed by these Japanese publications, who demonstrate clearly that perhaps you have different pathogenesis to explain the adenomyosis first, and second, the relationship between adenomyosis and endometriosis. And when we look at this study from Kishi in Japan, who published a very good paper on the adenomyosis, he performed the classification with intrinsic one and the extrinsic one. And he demonstrated that it was not the same disease. He demonstrated that you have significantly more posterior endometriosis in the pouch of the Douglas for the patient with intrinsic phenotype compared to the intrinsic one. And if we compare to our results in Paris, it is exactly the same results. That's once who said what Kishi called the intrinsic form is what we call the diffuse form, and what is extrinsic for Kishi is the focal form in the French classification. So if we have different pathogenesis, it is an hypothesis, it needs to be confirmed in the future. We can look at the clinical observations. And in our experience, it seems that when we look at the isolated diffuse adenomyosis versus the isolated focal, it seems to be not the same disease in the clinical observation. For the isolated focal adenomyosis, you have significantly lower body mass index, and it is correlated to significantly more surgery for uterine surgery and endometriosis. And I think that it is normal because we demonstrate that we have a strong association between focal adenomyosis and endometriosis. And for the diffuse adenomyosis, it's different. It is significantly more associated to the heavy menstrual bleeding compared to the focal adenomyosis. And this is reinforced by the recent paper from the team of Guo in Shanghai, who look at the stiffness of the myometrium to the ultrasonography according to the importance of the heavy menstrual bleeding, and you can see that the lesional stiffness is significantly more important if you have excessive heavy menstrual bleeding, and there is a correlation with the hemoglobin level and the uterine size. So we can postulate that adenomyosis is also, as the endometriosis, an heterogeneous disease, because you have different pathogenesis, you have different clinical signs, and when we look in our experience, you can see that the age is significantly completely different for the isolated focal and the isolated diffuse adenomyosis. And finally, when you look at the relationship between adenomyosis and infertility, it seems that, in our experience, the infertility is significantly correlated to the isolated form of the adenomyosis rather than to the diffuse form of adenomyosis. So, now if we take these elements into account, what could be the modern management of the adenomyosis? You have different options with the medical treatment, hormonal or non-hormonal. You can try to induce necrosis by embolization or HIFU, or you can perform different type of surgery, conservative or radical. The medical treatment with the IUD with levonorgestrel in a systematic review demonstrates clearly that it is a very satisfactory option to treat the patient with adenomyosis. And what is important also is the long-term effect of these drugs, and you can see that with more than 5 years of following, we have satisfactory results concerning the impact of the levonorgestrel on the heavy menstrual bleeding. And if you compare the IUD with the hysterectomy, you can see that the impact on the menstruation is exactly the same, but the quality of life is better for the patient with the medical treatment. The advantage of the IUD is that it is as efficient whatever the phenotype of the adenomyosis. Recently in Japan, very interesting paper from the team of Osuga, who they look at the hemorrhagic score with the levonorgestrel and they demonstrate clearly the efficiency of these drugs, and they demonstrate that the efficiency is better in cases of incipient type than in advanced type of the adenomyosis. And in the same paper, they look also at the impact of the IUD on the visual analog scale score, and they demonstrate the efficiency of the levonorgestrel IUD, and as for the menstruation, the benefit, the efficiency is more observed for the patient with the incipient type. Another excellent study from Japan, from Arada, who look at the impact in this prospective multicenter study. It demonstrates clearly the positive results. Whatever the objective is to treat the heavy menstrual bleeding or the dysmenorrhea, and the result is exactly the same, whatever is the indication of the prescription, either primary dysmenorrhea, heavy menstrual bleeding, endometriosis, or uterine myoma. And in this paper also, it demonstrates clearly the positive impact of the IUD on the pelvic pain score when you compare before and after the insertion. Interesting in this paper and very original from Arada is he looked at the risk of expulsion of the IUD, and he demonstrated it was less than 10%, 9%, and the risk factor after multivariate analysis are the body mass index, the fact that you have an adenomyosis, and the uterine cavity length. The other option for the medical treatment can be the Dynogest, and Osuka also demonstrate clearly with a randomized trial that not only the Dynogest is efficient, but it is also very well correlated for the patients. And when you compare the Dynogest with the Generich analog, that's true that perhaps the Generich analog seems to be more efficient to decrease the bleeding and the uterine volume, but you have, with the two drugs, with the two options, the same efficiency on the pelvic pain symptoms. Comparison between the levonorgestrel and oral contraceptive pills, only one prospective study, randomized study, who demonstrate that you have comparable improvement at 6 months in the two groups, but the improvement is significantly better for the IUD with levonorgestrel. As for the myoma, like Professor Donnet said, you will have in the future new possibilities which are under investigation. And as we demonstrate the possibility of the antagonist for the endometriosis and the myoma, I'm sure it will be also a good indication to try these drugs for the patient with adenomyosis. The uterine artery embolization can be in selected cases a good option for patients for which the medical treatment doesn't work or for which the surgery is difficult or risky. And you have also the possibility of HIFU, and you can see that after 3 or 6 months of HIFU, you have a significant reduction in the uterine size and in the adenomyosis. All these possibilities of the medical treatment, it is exactly like for the myoma, are not possible for the patient who want to be pregnant with or without an infertility. So the problem in the daily practice also is how to manage the patient with adenomyosis who want to be pregnant, how to choose between the surgery and the ART. The majority of the paper concerning the surgery of the adenomyosis came from Japan. And the most important publisher is Professor Osada. And in his main paper, he demonstrates clearly that when you perform this very difficult surgery, very hemorrhagic surgery, with some risk after concerning the obstetric outcome, he obtained 60% of pregnancy. But what is important in this series is to look at the results of this pregnancy. He performed very difficult and risky surgery, and 75% of the pregnancy are obtained with the IVF. And all the delivery were performed by C-section. Another very interesting paper of Kishi, who tried to precise what are the indications for the conservative surgery for the adenomyotic patient who want to be pregnant. He demonstrated clearly the importance of the age. There is no place for the surgery if the patients are more than 39 years old. And he demonstrated also, like from Osuga, that 50%, a little less, of the pregnancy after the surgery are obtained with the IVF. And what is interesting in this paper from Kishi, he looked with the multivariate analysis to try to define what are the risk factors which impact the results of this conservative surgery. He demonstrated that you have two negative impact factors. First, what is normal, the age. And the second, which is very, very, very interesting, is the fact that you have a posterior wall involvement. That wants to say that the fact that you have a posterior focal adenomyosis. And in our experience in Paris, when you look at the patient with deep endometriosis and an association with a posterior focal adenomyosis, we demonstrate that these patients are the patients with the more severe cases of the deep endometriosis, with significantly more multifocality of the deep nodule, significantly more infiltration of the intestinal wall, significantly more number of deep nodules in the intestinal wall, and significantly more ovarian endometrioma. That wants to say that you will have not only a difficult surgery to perform the adenomyosis management, but because of the association of the focal nodule, you will have also a very difficult surgery concerning the deep endometriosis surgical management. And recently, Carmona demonstrated clearly a very interesting study published 2 months ago that you have a strong relationship when you look at the surgery of the deep endometriosis by laparoscopy between the fact that you have adenomyosis and the fact that you have associated adenomyosis to the deep endometriosis. And you can see that the risk factors related to surgical complications are the bowel resection, the necessity to perform bowel resection, the necessity to perform an hysterectomy, and the existence of an adenomyosis. So all these results from Barcelona and Paris go exactly in the same direction than those observed by Kishi in Japan. And finally, the parameter which is in favor for Kishi to perform the conservative surgery is the fact that you have previous failure for IVF treatment, with an odds ratio very important, 6.2. And when we look at the results of the conservative surgery for the adenomyotic patients, which failure of IVF treatment, he obtained 60% of pregnancy. But what is important also is to look at the result. 90% of this pregnancy were obtained with the IVF. So I think that for this patient, if the surgery has some benefits after the IVF, why not to perform systematically in the first step the IVF procedure rather than the difficult surgery? How to perform the IVF for this patient with adenomyosis? It is now well recognized and demonstrated scientifically that you need to use long protocol with desensibilization. The generation antagonists are very helpful in the management of this patient because it will decrease significantly the risk of miscarriage. And if you use the frozen transfer, it will be interesting, as it was demonstrated in this Chinese, and we have exactly the same result in the department, with the downregulation to use an HRT prescription before to perform the frozen transfer. And what could be the place of the frozen transfer for this patient with adenomyosis and ART? We look, in our experience, at the benefit to perform frozen transfer for the patient with endometriosis, and you can see that when you perform frozen transfer for the patient with endometriosis, we significantly improve the chance of pregnancy. But what is more important is these results, which are submitted for publication. Each time you perform a frozen transfer, you will increase the chance of pregnancy. But you can see that the rate, the benefit of the frozen transfer is significantly more important for these endometriotic patients when they have an associated adenomyosis. That's why to say that in the previous part, we try to systematically perform frozen transfer for the endometriotic patient, and now we modify slightly our management, and we propose first the frozen transfer for the patient endometriosis and adenomyosis. The duration of prescription of estrogen needs to be 28 days. And if we want to conclude, the problem of the diagnosis, the clinical symptoms, no specific clinical symptoms. I hope that you are convinced that now the adenomyosis is an heterogeneous disease and sometimes can be asymptomatic. So with the clinic, the questioning and the clinical examination, you will have only a suspicion of adenomyosis. So the revolution during the last 10 years is the possibility of the radiology, first imaging process, the transvaginal ultrasonography and or MRI, and you will have the confirmation of not only the adenomyosis, but of the phenotype of the disease. It is an heterogeneous disease, whatever the classification, the Japanese one, the French one, there is a lot of classification. You have diffuse adenomyosis and focal adenomyosis. In my opinion, the strong collaboration between the gynecologist and the radiologist, the key point in the management and in the diagnosis is the radiology, because you will confirm the diagnosis. Second, you will know if there is or not an associated endometriosis, and you will precise the phenotype of the endometriosis, and you must be obsessed to know if there is or not a focal adenomyosis. Why? Because focal adenomyosis is a marker of the severity of the deep endometriosis when you have an associated deep endometriosis, and it seems that this focal adenomyosis is a negative prognosis factor for the fertility of the patients. So the management will depend on the age, surely from the patient's intention and priority, the clinical signs, IUB, pelvic pain, and or desire of pregnancy, the phenotype of adenomyosis, the association or not of an endometriosis, and also, as it is well presented in the Palm-Cohen classification, if you are or not some associated other hemorrhagic disease. So we can summarize for the patient with heavy menstrual bleeding. The first question will be, is there any infertility situation? And I think that if the patient is infertile, because of all the results we demonstrate, I think that if she is not spontaneously pregnant, because it is not because you have adenomyosis that you will be systematically infertile. But if she is not spontaneously pregnant, I think that you need to perform first an ART, and why not, according to the result of Kishi, to discuss of the limited place of the surgery if you have 2 ART failure. If there is no infertility, the question is, do you want to have some pregnancy? If you don't want to have pregnancy, I think it is like Jack said, and you see that we have the same evolution for the myoma, for the adenomyosis, for the endometriosis. We change of paradigm for this patient. You will prescribe the medical treatment, and I think that with the Dynogest or with the IUD with levonorgestrel, we have very, very excellent results with few side effects, cost effective on the long term. And if these medical treatments are not efficient, or if the patient will refuse, you will discuss the surgery, the uterine embolization, or the IFU. If the patient wants to be pregnant but not immediately, it is a deferred desire of pregnancy, you will prescribe the medical treatment, and when she wants to be pregnant, you will perform the IVF. And if the desire of pregnancy is immediate without infertility, you will perform an ART, as we previously said. And to finalize, I would like to invite all of you to come in 4 months in Abu Dhabi to participate and to share with us concerning your interest with endometriosis, myoma, and uterine disorder in the 9th Congress of the CEU. Thank you so much.
Thank you, Professor Chapron, for this great presentation. Unfortunately, we are run out of time, and just one comment or question will be allowed. It's okay. If anybody have just one question. Okay.
There is observation during cystoscopy to find the cystic type, subendometrial, the cystic types. When we incise, chocolate-like material comes out. This is cystic endometriosis or another thing?
No, I think it is cystic endometriosis. You have the crypt who is arriving near the cavity, and you can perform the incision. You have the Belgium people from Gortz and so on. They try to do that with satisfactory results.
Why not included in the classification?
Because it's impossible to put all these elements. None of the classification are perfect. So, but perhaps we must take reflection according to this specific point in the future, surely.
Relation between age and debarity for adenomyosis.
Agent?
Age and debarity. Barity.
Parity, yeah.
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 For the occurrence of adenomyosis in our basic teaching, adenomyosis is a disease of high barity, and endometriosis is a disease of low barity.
No, because before we are not able to perform the diagnosis of adenomyosis because we have not the possibility of the radiology. But now we know with the radiology that it's perfectly possible for the patient of 30 years old to have adenomyosis. So I think that we must take care, even for the young patient, the possibility of adenomyosis. And you have 3 groups of patients: the patient with isolated endometriosis, the patient with isolated adenomyosis, and the patient with a combination of both. And perhaps in the future, we will have different management for these 3 groups of patients.
Thank you.
Yes, thank you. Okay, we'll move to the next speaker. Thank you, Professor Chapron.